Good morning, everyone. My name is Ellen Barra, and I'm a specialist with our Provider Outreach and Education Department. On the call with me today is Leanne Foster, my friend and colleague, and she will be watching our chat. There's also going to be some information she's going to be placing in the chat for you, and you'll see that as we go through the presentation. We also have a member of our medical review staff on the line with us today. She may be able to answer some of our questions. If I'm not able to answer something, she may have some additional information she'll want to pop in with. Otherwise, she's just in a listening mode. We do thank you for being here today, for taking time out of your day to listen to this presentation. We do encourage you to take the survey, and you'll have several opportunities to do that as we go through the survey. For those listening through our encore presentation on our YouTube channel, you also have an opportunity to take the survey and to provide your feedback to us. In YouTube, the survey is in the description of the video. And then at the end of the presentation, there's a link where you can go back to that description. On our website, the link is right under the video on the right-hand side. The next thing that we want to talk about is just our disclaimer, and we do provide this during all of our presentations. This presentation is as accurate as we can make it as of today. Medicare rules and regulations, however, do change often. If you've been with Medicare probably for more than a month, you've already figured that out. The CMS rules and regulations are the final determinant of coverage along with your documentation. If we have time at the end of the presentation, we will respond to your questions based on how you've asked the question. But again, Medicare rules determine final coverage. CMS does prohibit recording of the presentation for profit-making purposes. If you're doing screenshots, if you're recording the presentation, we would ask that you not do that. Again, we are recording this. It will be available for you after this presentation. The next thing that we have is just the CPT copyright notice. CPT owns the codes and the descriptions. CMS does not own those. So this is just information on that copyright notice. If you disagree with the copyright notice and don't intend to kind of follow that, then you can disconnect. We just have a real quick slide here for you to let you know about some new information. The interactive voice response system currently has an eligibility function in it for your Medicare patients. That eligibility function will be removed by 3/31 of 25. We do have other resources though for you in order to get that eligibility information. One is the secure section of our portal. You can sign in, you can get the eligibility information you need. You can also get that through direct data entry, which is the Part A function. And then you can do what's called the HETS transaction, which is a HIPAA eligibility transaction system. That's the 276, 277 reports and submissions, and that will bring you back eligibility information. The change request, because this is from CMS, that change request number is listed there for you. So what are we going to talk about today? Well, our medical review department is going to start a review process on procedure code 99214 for our J8 providers. Now, if you're from J5, don't disconnect because that process could kind of go over to you guys too. And the information that we're going to provide here today is also valid for our J5 providers. We're going to provide information on why we're performing this review, and we'll go over the documentation requirements for the 99214 level of service, chosen either by time or medical decision making. And then we've got a few examples that we'll go through. Our plan is that we'll be able to take questions that you place into the chat during the presentation today. We do have a lot of information that we're going to provide to you. If we can't get to all of the questions, we will be sending you a document with the questions and the answers to all attendees following the presentation, probably within 2 weeks. So one of the pre-submitted questions that we had, excuse me, sorry about that, is will Medicare require documentation on all 99214 procedure codes that you submit? And the answer to that is no. We will request documentation. This is part of what we call our targeted probe and educate review. And so based on the data analysis that we will be doing, we'll be requesting documentation from certain providers. We'll send you a letter, an additional documentation request, let you know the claims that we need that information back on. You submit back the documentation, we'll review it, and then either pay or deny it from there. Because of that, the way that we're going to do that, though, you do want to make sure that all of your addresses are updated within the PAYCO system. That's the provider enrollment chain and ownership system. So, because we're going to send to those addresses that are listed within the PAYCO system. If your address is not updated in there for some reason, then you're not going to receive the letter, and then Medicare is going to have to deny the service until we receive that documentation back. So what we have for you up on the screen is just some acronyms that we'll be using throughout the presentation today. The first thing that we're going to be looking at when we're reviewing any documentation is the medical necessity for the service. Evaluation and management services, along with anything else, have to be reasonable and necessary. Your documentation must support the diagnosis and treatment you're providing for that patient for the illness or the injury or the functioning of a malformed body member. So why are we getting ready to review the 99214? Well, we're doing reviews on this based on another TPE that we were doing. We were reviewing submission of lipid panel charges. Well, part of the documentation for those lipid panels was the actual medical record coming from that ordering provider. In our evaluation of the lipid panels, we also discovered that probably that documentation really wouldn't support the 99214. So we did some data analysis, and now we're expanding that review or starting the new review, a targeted probe and educate review for the 99214 procedure code. In a lot of cases, what we found was the order of those lipid panels were not medically necessary for the patient under Medicare's guidelines. We do have some information available for you on the coverage of lipid panels. Keep in mind, this is very brief information. Medicare can reimburse the lipid panel under the cardiovascular disease screening test. And this is for patients without apparent cardiovascular disease itself. But Medicare pays for that once every 5 years. And then we can also reimburse a lipid panel under the medical necessity guidelines. And there's requirements for that, how often you can do that, what has to be going on with the patient, etc., in order to do that. We've done some education on this, and we're going to place the links to that education within the chat, but you can find these on our YouTube channel. You can see there preventive services for cardiovascular disease. We have both a clinical one and then a billing one. We have medical review findings from these lipid panel reviews. And then we also have evaluation and management, choosing your level of service. So when you're choosing your level of service, you choose based on either the time, and that's the total time that has been spent on that patient on that date of the encounter, and that includes both face-to-face and non-face-to-face activities. You can also choose based on the medical decision making. If you use medical decision making, you must meet or exceed two of the three elements. And you can see those listed there: the problems, the data, and then the risk to the patient. So what we have up on your screen now is the definition, the CPT definition of that 99214 procedure code. So you can see there that it's a moderate level of medical decision making, or its 30 minutes must be met or exceeded. One of the things that we're suggesting to you is to do a self-audit. Take a look at how often you're billing that 99214 procedure code. If you're billing it for every patient that walks in the door, you more than likely have a problem that needs to be addressed. One of the things that we hear back from providers sometimes when they do bill everything the 99214 is, well, my patients are sicker than everybody else's. No, really, they're not. And your documentation has to support that particular procedure code. Another pre-submitted question that we received is, are there any diagnosis codes specifically that would not support a 99214? And the answer to that is no. Any diagnosis could support that. It's all based on the documentation. When you're going under medical decision making, it's going to be based on the problem that has been documented, the data that has been accessed. And again, the requests for that data do have to be medically necessary. And then the risk to the patient as part of that medical decision making. So let's take a look at time then. Time is identified within the code descriptor itself. As we saw on the 99214, you must meet or exceed 30 minutes. Excuse me. This time is on the same calendar date, and it includes both face-to-face and non-face-to-face time. Get your physicians and practitioners involved in documenting that non-face-to-face time. We'll show you in just a minute what those activities include. It's time by the practitioner, so any time spent by your ancillary staff would not count toward this. And then that last bullet point, you want to be documenting the specific time. A lot of questions that we receive is, well, can I use a standard statement? Time was 30 to 44 minutes or something along those lines. That's really not your best practice. Your best practice is to identify the specific time and to identify the activities that the provider has done for that patient on that calendar date. And again, take a look at that face-to-face time. Don't leave money on the table. That could move your procedure code into a higher level. So what we have next for you are just some of the non-face-to-face activities. Preparing to see the patient, if that's done on the same calendar date. Obtaining separately obtained history, performing the medical exam, ordering tests and procedures, etc. Look at that second bullet point there. The time that your physicians and practitioners spend in either documenting the encounter itself or spend in dictating and then looking at whether or not the information was correct. As long as it's on the same calendar date, that time counts. So again, don't leave money on the table. Make sure your physicians and practitioners are documenting that. The other three that are listed there, you can see has the statement when not separately reported. So if you're doing an interprofessional consultation, as an example, and you're going to bill for that procedure code, you don't count that time. And really, you need to identify within the medical record, I spent 15 minutes talking to Dr. So-and-so, and here's what we talked about, and here's what I spent on my E&M service. One of the pieces that we have seen within documentation, it will say the E&M service was 30 minutes. We have carved out any additional time. That's an okay statement. It's not your best practice, though. Best practice is to identify both of the times. If you're independently interpreting a test result, so you're doing a professional component of a chest x-ray, for an example, if you bill for that, you wouldn't count that time. And then care coordination is also something you would not count separately. You would not count performance of other services that are separately reported, any travel time or any teaching time that is general and not specific to that individual patient. So now let's talk about medical decision making. Well, as we showed before, it is comprised of three different parts or three different elements: the number and complexity of problems, amount and complexity of data, and risk of complications. So let's take a look then at the definition of your problem. This is, and it's up there on your screen for you, this is what your practitioner documents he or she is treating during this encounter. You'll notice in the definition, you may not have a diagnosis yet. Patient could be coming in with abdominal pain. You don't know what's causing that yet. You can identify things that your doctor is thinking about, maybe ruling out appendicitis, etc. What we're looking for here is really the doctor's proof of thought. Okay, so part of your description could be the symptoms that the patient is having, how often it happens, what's the level of pain, etc. Now, you can use your expertise as coders and billers to determine the problems that the physician is addressing. You may be able, through the documentation, also to determine what level that problem will fall into. But if you can't, if it's not really clear in that documentation, go back to your practitioner. Have them tell you what is the level of problem that they're addressing today. And addressing the problem is real important. You would consider a problem addressed if you're considering that problem to treat the reason for the encounter. For example, the patient's reason for the visit today is pain in the knee. After addressing or considering the treatment for that pain in the knee, your physician documents they're addressing and analyzing the diabetes for any consideration of a possible reaction with the steroid injection, any effect that the diabetes may have on that pain in the knee, etc. Another thing that we see quite often are blanket statements, all chronic conditions addressed. If it's not in the documentation that you addressed it, then we would not count that you addressed it. Needs to have in there what they did, how they addressed that particular problem. You can consider all of the problems that were addressed, such as the patient comes into the ER maybe because they passed out. The patient discovers during the encounter that the patient has a tumor visible through the eye. Okay, that's going to increase your problem. It's not just that the patient, kind of fell out, but now we have bigger stuff going on. One of the things that people ask us about quite often is the COPA, or complexity of problems addressed. If it's just listed, but it's not addressed, and there's no documentation to show it's addressed, you would not count toward your level of problem. Again, think about the patients that we're talking about. We're talking about Medicare patients. So these are patients who are over age 65 or they're on Medicare based on a disability. They could have 27 different diagnoses, but what is your physician addressing and managing today? That's what we want to look at. Patient has, again, 27 diagnoses, but today they're coming in for the rash on the elbow. That's the problem that they're addressing today. So that's what you're going to actually code to. You may have statements in the documentation that say the condition is managed by Dr. So-and-so. If your practitioner did not address it, then the fact that the patient has it does not count toward your level of problem. The next thing that we have is data analyzed. This goes back to proof of thought. The practitioner is reviewing or analyzing any type of test results to help determine the plan for that patient. When you see the patient in June, possibly you analyze the INR results, and this will help determine the plan. This could be keeping everything the same. It could be making adjustments, obviously either way. Tests and things that you order are presumed to be analyzed. If there's no documentation to show that the physician needed to use that information within their plan of care, if there's no documentation on the proof of thought as to why they were ordering that particular test, then Medicare will not be counting that when evaluating the evaluation and management service itself. This goes into the category 1. In ordering tests, when you're ordering a test, a review of that test is part of the order. Medicare, again, is expecting you to analyze that information. If you're ordering tests simply to meet the level, something along those lines, I've actually had that question from a provider. Really, it does not meet medical necessity. It could also subject the patient to unnecessary testing, and it would cost the trust fund money. So we don't want to go there if we don't have to. A pre-submitted question we had is pulling the results into the medical note count as analyzed. Well, where's the proof of thought? How is the practitioner using that information for the medical decision making of that patient? So let's look at tests. It gives you the definition there: imaging, laboratories, psychometric, physiological data, etc. A unique test is going to be based on that procedure code, with one exception. If you're doing a procedure code that includes other items, maybe you're doing a lab panel or something like that that includes multiples, the lab panel would be that unique test. You would not count each of those as a unique test. You can also see on here that pulse oximetry is not considered a test. We've heard from some providers that this is part of taking their vitals, but it's not considered a test by the AMA. Category 2, under data for moderate or high area, is for an independent interpretation. This is similar to what a radiologist or a pathologist would do. You're looking at the x-ray or the slide presentation, etc., and you're providing an interpretation of that actual x-ray or pathology. You're going to have a report of that within your documentation. You're the one deciding what that test shows. It's not reviewing the radiology report It's not analyzing the chest x-ray, for an example, and then making a decision from there. We are looking to see an actual separate report within your documentation. The AMA states that if you're ordering and performing the test, you would not count that separate. So if you're going to bill for the professional interpretation of that chest x-ray, then you wouldn't count that as part of your MDM. If you're not billing it, then you can count that. If your group is performing the technical portion of that chest x-ray, you can still count that as part of your E&M service, that professional component that you may be doing. A pre-submitted question that we had, can we count the same test multiple times if we ordered them for different reasons? And the answer to that is no, it is still one unique test. Another pre-submitted question says the medical record shows that the test was intended to be ordered, but there actually wasn't an order for that. You would need to have additional documentation there. You can include testing that was considered but not ordered. So maybe you're considering you want to do a CT scan with and without contrast, but after further discussion with the patient, you decide, no, this is not what we want to do, or the patient refuses or something like that. Document that. You still have that work that was provided there. The next thing that we have is the risk. And providers are really kind of having problems with this. It's the probability or the consequences of an event. So that's your encounter. So what are you deciding to do for that patient? And what is the risk to that patient from the decision? One of the, or an example we could use is you have a patient with a stable chronic condition and you renew the patient's prescriptions. What's the risk to that patient from simply renewing those prescriptions? Are there, has that patient been on that medication for a long time? Is it a new medication and there's a very real possibility of some fairly devastating side effects that you need to watch for? That's what you're looking for when you're looking at risk. I'm deciding to do this, and therefore this is the risk to the patient from my decision. Again, it goes back to that proof of thought. What's the probability or consequences anticipated for that patient from the medical decision making that has been made? One of the questions that we receive quite often is we decide to send the patient to the emergency room in order to be admitted. Well, are you making the decision that the patient has to be admitted? And if so, why are they going to the emergency room? If you're sending the patient to the emergency room for that doctor to make the decision as to whether or not the patient should be admitted, then you really didn't make that decision today. You referred that patient to someone else for them to make that decision. Another pre-submitted question we get talks about referrals. If you evaluate the patient and you determine that the patient's care really needs to be with Dr. So-and-so, again, what is the risk from the decision to refer to Dr. So-and-so? That's what we're looking at when we're looking at your documentation for risk. We've got some definitions here for you. The first, or this one, is the morbidity. This is the AMA definition. Mortality, of course, is fairly easy to understand. This is whether or not the practitioner believes the patient and has a reasonable expectation that the patient could die from that problem addressed and the treatment plan for that patient. Morbidity is where the patient could suffer long-lasting issues from the problem and then the treatment plan that was chosen for that patient. The next thing that we want to talk to you about here is prescription drug management. This is an example on the risk table from the AMA. And I think the first thing to remember is that it is an example. It's not an automatic. One of the questions that we continue to receive, and one of the ones we receive the most pushback on, is I evaluated their medications. Therefore, it's an automatic moderate level risk. And that's not what the AMA says. And in fact, on your slide, we have a link to a document from the AMA that specifically addresses this question. For an example, you order an antibiotic for the patient with a upper respiratory infection. What's the risk to that patient from taking that medication? That's the decision. I'm going to order an antibiotic. Has the patient taken that medication previously? Another example could be the practitioner is seeing an established patient and renewing their medications. Again, what's the risk to that patient of mortality and or morbidity? If the documentation doesn't support a moderate risk other than the use of the words prescription drug, then the service probably would not qualify for that moderate level. Another question that we get on the prescription drug management is, number one, does this apply to over the counter? Well, if you're simply telling the patient, take 2 aspirin and call me in the morning type of a thing, it would not. If you're looking at that over-the-counter medication and you're having to make assessments on that, either as it pertains to other medications the patient may be on, you're evaluating that for a much higher dosage than what would be recommended from the over-the-counter itself, then that could count. You need to have your physicians document that. What is their proof of thought? And then what is the risk to that patient from that? Another question that we get quite often is, can you count prescription drug management when you do an injection in the office? And the answer to that is no, that's not prescription drug management. It's actually a procedure that you're doing, whether you're doing an IV, IM, sub-Q, etc., or you're doing like an injection into the joint. There still could be risk to the patient for that, but it would not fall under the example of prescription drug management. Another pre-submitted question we had was, what about starting a medication in a hospital setting and then continuing to watch the medication for efficacy during the stay? Well, again, when did you make that management decision to start that patient? What's going on during the encounter today where you're evaluating that? And that's what you want to be looking at as far as your risk. Now, that was kind of a general overview of choosing your level of service. The encore presentation that we have in our YouTube channel goes into a lot more detail than that. And we are doing, in fact, we did either last week or the week before, we did one on time, just questions and answers. Earlier today, we did one on the problem element. And then next week, we're going to do on the data and on the risk. The data and the risk are available for registration should you choose to. So what we're getting ready to go into now are examples of medical records that we have received. So we have worked with our medical review department to kind of dissect these records as far as the evaluation and management service goes, to come up with a procedure code that we believe is supported. Now, one of the things I want to let you know about is if we're looking at your documentation and we decide no, it's not, the 99214 is not supported, you have an opportunity to appeal. When you appeal, however, you need to be very specific in that appeal as to why you believe the documentation does support a 99214. If we downcode it or we deny it, we're stating we've evaluated what you have. We don't think it supports that level of service. So you can see here in the example, our patient has been diagnosed with stage 2C prostate cancer, and now the patient is presenting for reevaluation. The patient is taking a prescription medication. Patient is to come back in again. The physician performed the appropriate medically necessary history and exam. One question that we receive quite often is about a diagnosis of cancer. When do you look at it as a diagnosis of cancer versus a history of cancer? Well, this then is going to be based on the documentation within the medical record. Are you really still treating the cancer? And by saying that, I'm not saying the patient is still undergoing radiation therapy or undergoing chemotherapy, but it's an active treatment of that prostate cancer, for an example, versus you're now doing the 1 year and 5 year and 10 year follow-ups from that cancer. Those would not be a diagnosis, or it would not be a problem of prostate cancer. Whereas, if you're still seeing them 6 months following their treatment, it's probably still a problem of cancer. So the next thing that we have then is our level of service. They identified 20 minutes as the time that they spent. They identified the problem addressed, the cancer of the prostate. However, the documentation did not provide any status. So it didn't tell us, is it getting better? Is it getting worse? Is it in remission, etc. It did tell us that the treatment completed back in April of 2023. So based on this documentation, our problem is low. We have a stable acute illness. Excuse me. There was no indication in the note of how long the treatment for the prostate cancer was or how long they had it. What the provider is expecting to happen in the future. They did have multiple lab tests ordered, one of which, of course, was the lipid panel. Because of the other tests that they had ordered, the data then would indicate moderate. And then in the risk information, there was no identified risk. And so therefore, this would have to go down to straightforward. So in looking at this documentation, it's not a 99214. Based on time, it's a 213, and based on medical decision making, it's a 213. Example number 2, we have an 80-year-old female who presents for checkup, balanced diet, patient exercises, past medical history indicates, and it gives you some information there. We have a body mass index, which is too high. And then we have, under our exam, we have pitting edema in both lower extremities. There was no time identified within this medical record, and you don't have to document time. It's always a good idea to do that, but it's not required. If you choose only medical decision making, that's fine. So the problem addressed was the history of the high cholesterol. This is a stable chronic illness. The patient was at goal, so therefore it is a low problem. They did have multiple lab tests that they ordered, and so that would go into the moderate section. but again, there's no risk identified. This procedure code level would be the 213, not the 214. Example number 3 then, patient is here for a 6 months follow-up. We have diabetes. We have an insulin needle broke off in the abdomen. I don't know about you guys, but I don't want that. We have hypercholesteremia. They're indicating that the patient could not tolerate the statin that they had previously prescribed. You can see there they're considering comorbid condition and high cardiovascular risk, and they're adding the Repatha drug and for that injection, and then it gives how often, etc. They did perform the appropriate medically necessary history and exam. So the provider documented 30 to 39 minutes. Ranges are not your best practice. You really want to document the time that was spent. They documented the problem addressed. They documented the labs. So the problem is low, labs are moderate, and then they also identified the risk. And the risk would be moderate in this case. So based on the documentation here, we have a 99214 based on time, and we have a 99214 based on the medical decision making. So let's say, for an example, that the doctor in this case documented 25 minutes. So our procedure code based on time would be the 99213. Our medical decision making supports a 99214. Bill the 99214. That's the most advantageous to you, and your documentation supports it. You can submit based on and choose your level of service based on either time or medical decision making, whichever one gives you the higher level of service, as long as it's supported. Example number 4, we have our chief complaint of diabetes. The patient needs their medication reviewed. You can see the last A1C there was 3.7. We have additional problems that are listed, the fatigue and the ESRD. There's no information on the treatment of the end-stage renal disease. More than likely, this is being treated by an endocrinologist or a nephrologist, one of the two. The fatigue is due to the dialysis itself. We do have that the patient is on medications. The note itself did not indicate any amount of time. The problem is moderate. We have one or more chronic illness with exacerbation. They stated that the diabetes with unspecified complications. Your best practice really is going to be to list those complications. This one, when I was reviewing this one again, I would really have to think about that. Since they did not list the actual complications and the A1C is at 3.7, I'd really want to know what those complications were in order to stay with that moderate level. They only had one lab test that was ordered, which was the lipid panel. And then there was no identification of risk. They simply renewed a medication based on what they're providing to us in the medical record. Therefore, this one would go down to the 99213. So that kind of gives you an idea of how we would be looking at the documentation. Now, obviously, what you have in your slide presentation is not the actual documentation. There were too many pages and I could not get it redacted and placed in the slide deck itself. So I took the information out of the notes and put them in here. So we're going to look at everything that you send us when we're evaluating this documentation. We want to provide we want to see support for that procedure code. So that's what we're going to be looking for. Can we support the 99214 procedure code that you submitted into us? If we can't, then unfortunately we're going to have to downcode the service. I provided you here with some resources. That last one on that page is information from the AMA that talks about that prescription drug management. And then just an FYI for you, the evaluation and management service guide by CMS has been updated within the last 2 weeks. There's not a whole lot of updates when I looked at it this morning, but just to let you know, it was updated in September of this year. We have some additional resources for you there on the lipid testing itself. We're getting ready to open it up for questions in the time that we have left. I've got just one question here that we can kind of look at. But before we do that, I again just want to remind you that we will have survey information available for you at the end of this presentation. If you're listening to this based on our encore presentation, you also have the ability to take a survey and to provide us with your feedback. One of the pre-submitted questions that we had is, and I feel sorry for this person, but their physician refuses to update to the new guidelines. They want to continue using the 95 or the 97 documentation guidelines, which are no longer in effect. So they really kind of ask, what they should do. Well, you want to continue to educate your physicians and practitioners. You want to continue to go back to them and ask questions when the documentation would not support a procedure code. And then the other thing I want to let you know about is don't bill something you know is wrong. Your physician and practitioner is ultimately responsible for what is submitted into Medicare. However, some of the Office of the Inspector General investigations and convictions have also included coders and billers because they knew what they were billing was incorrect. So go back to your physicians and practitioners rather than simply submitting something incorrect. So now we're going to open it up for questions. So Leanne, I'm sorry, what questions do we have?
We do have quite a few, Ellen, so we'll certainly go ahead and run through what we can. The first one is, if a patient came in for an acute condition and the provider documented in their assessment and plan, patient due or overdue for labs today with the chronic diagnosis code, can we count the labs?
Yes. Yeah, because you're doing that work, even though the labs are not necessarily for that rash on the elbow for which they came in today. It's still part of your E&M encounter. So yes, you can count them.
Next question is asking if it is appropriate for providers to round time, for instance, rounding to the nearest 5-minute mark.
Medicare doesn't expect the physicians to use a stopwatch on themselves. That's unrealistic. But they need to be as accurate as they can. If they round to 5 minutes, Medicare's not going to have a problem with that. The only caveat to that is if we see all of documentation, if we're looking at it and everybody's documentation is 35 minutes, Medicare's going to go, I wonder if that's accurate. So, but if they're rounding, one way or the other, that's fine.
All right, next question. So per the problem section, I have used pain has not changed or pain improved to indicate stable chronic conditions, and pain has worsened to show a progression. This often determines if I choose a level 3 or 4. Since pain is not normal, should those pain has not changed still indicate a progression? And if the rest of the documentation is adequate to be a level 4?
Well, if I'm understanding the question correctly, you're asking if you can include pain as an unstable or, the patient is not at goal. And the answer to that really is no. It's all going to depend on what you're treating. For an example, if you're treating a patient with osteoarthritis, the patient's going to have pain. And we know that that's the nature of the disease. But what is your goal for that patient? Is your goal to have that patient's pain level at a 2 or less? So if it's at a 2 or less, then you have a stable chronic condition. If it's at a 4, then you don't have a stable chronic condition. It's all going to depend on what's the goal for the patient, what's happening with that patient, what's the diagnosis information. Next question.
All right. The next question is, do urinalysis and urine culture count as two data points, or does WPS consider them overlapping?
Okay, tell me the name of the tests again, Leanne. I'm sorry.
No, not a
Urine
problem.
culture.
It's urinalysis and urine culture.
Those would be two different procedure codes. And if I'm understanding the question correctly, and if I remember the codes correctly, a urinalysis is not part of a urine culture. So if your physician needed answers from both of those, and they're different procedure codes, then both of those would be a unique test.
All right, thank you. Next question is, if a hypertensive kidney is seen for the kidney only and the provider mentions hypertension stable in the assessment, can we capture the I-12.9 for risk scores and 18, but not count the hypertension?
Okay, I'm assuming you're giving us a diagnosis code, okay, but I obviously don't know what that is. If your physician is treating that patient for the hypertensive kidney and the documentation supports it, and for the hypertension, then you look at both of those problems. I would guess that the hypertensive kidney is probably going to give you a different level than simply hypertension, but you would look at both of those because your physician has documented, excuse me, he's evaluating both of those.
All right, next question. For the question regarding a test being intended to be ordered but just wasn't, what about a scenario where it was not decided against? The problem was a workflow issue and getting the order for the test placed. For example, the nurse didn't know the correct workflow for ordering the labs and therefore weren't actually ordered. They're asking if you could please clarify that we can still give credit in data for the intention to order those labs.
Sure, you can. Yeah, you have an oops there. And obviously you need to train the person who made the oops and get the test ordered because the physician documentation is going to support he or she wants that information in order to treat the patient. So you just go back and order the test at that point and you're fine. The caveat there is if you saw them today and your physician said, yes, I want to order whatever it is, that didn't happen. You see them next week, your physician realizes that didn't happen. You don't count the order again. You're only going to count it in one place. But yes, you can count. Next question.
Next question is, if a provider documents that the plan is for the patient to get a test, say an EKG, in a year, but there is not an associated order, can that count towards data, or does there need to be an order in the system at the time the provider drops the charge?
No, your physician says, I need you to get an EKG and I'm going to order that. Whether you drop the order in that terminology, whether you have the patient call back in a year's time to get that order, today your physician says, I want an EKG. And so count it. And then Leanne, this will be the last question.
Okay. And the last question is, does refilling a prescription count towards level of E&M selection for moderate level?
It can, but not always. And that's really what I was trying to emphasize with you within that particular slide. Um, what is listed in the risk section in that table are examples. So prescription drug management is not an automatic moderate level of risk. We gave you the examples. You're going to reorder a medication. Patient's been on this medication for 3 years. What's the risk to the patient of them taking it? None. Therefore, it does not go in moderate level. Another situation could be you're ordering the medication for the patient, and there is a very real possibility that there could be drastic side effects that could move it into high. It is the determination of and the documentation of your physician and practitioner of the risk to that patient from the medical decision making that they have made. You know, think about when you go to the doctor, okay? They're going to renew your hypertension medication, high blood pressure medication, and you're on high blood pressure medication because you have to deal with Medicare. Okay, they're going to renew that. What's the risk to you from continuing to take a medication you've taken for the past 5 years? That's what you want to be looking at and looking for within your documentation for the level of risk. So we're going to stop the questions at that point. Any questions that I was not able to get to, we will be putting together in a follow-up document, and that will happen sometime within the next 2 weeks, and then that will go back to all attendees. So the next thing we want to show you is information on our survey. I'm hoping that I provided you with an excellent customer experience today. I hope you believe that, this was a good webinar to spend your time on. You can use the QR code there with a smart device, smartphone, etc. When you leave WebEx, what's on the right-hand side of your screen is what your screen will look like. It's simply WebEx telling you that we, WPS, want you to go somewhere else. If you hit that blue continue button, then it will take you into the CMS actual survey. Doesn't take very long, but it allows you to provide us feedback. If you feel like I did a great job, please tell me that. If there are things that you think I could improve upon, then please tell me that too. We use this information to, try and improve our presentations on a continual basis going forward. In addition to that, you will also have an opportunity to tell us what other subjects you would like us to provide for education. We pay attention to that too. Here in just a few minutes, you're going to receive an email from WebEx, and it's going to be your certificate of achievement. Number one, it's going to thank you for attending, and Leanne and I both thank you for attending today. But it also has your certificate of achievement. It will provide the title of today's presentation, the date, and then the contact hours. We don't issue index numbers, but you can use this email with your accrediting organizations. And then if you do have additional questions following this presentation, we can take those for up to 7 days, and then any questions we get through that will be part of that follow-up document. So don't anticipate the follow-up document tomorrow. We will wait for that 7 days to see if we get anything else in. So on behalf of Leanne and myself and our medical review staff, we want to thank you very much for your attendance today. We hope that this information will help you once the medical reviews begin on the 99214 procedure code. And so therefore, when our medical review staff get them, we can say, yes, that works, and pay you for the service, and everybody's done. We do ask you to take the few moments to complete the survey. whether you're attending live or you're attending through our encore presentation. We do want your feedback. So that concludes the presentation for today. Thanks and have an absolute fantastic day. You can now disconnect.